Welcome, everyone. We're so glad you've joined us today. It looks like we still have people jumping on, but we are excited for you to join us for this important and timely session. If you've ever been felt
Hmm.
frustrated for having SRP claims denied, you're not alone. And today we're going to discover a better way forward. So I'm excited to and honored to introduce to you Dr. Jim DiMarino. He is the Chief Executive Officer of Practice Booster, and he's also the Chief Clinical Officer at eAssist Dental Solutions. Dr. Marino is one of the dentists, he's one of dentistry's leading experts in coding and documentation, and he'll be sharing practical strategies you can use right away to prevent denials, improve reimbursements, and also strengthen your documentation standards. So, with a quick note, just a couple of little housekeeping items before we begin. If you have questions during the presentation, please enter them into the Q&A box at the bottom of your Zoom screen, and we'll do our best to answer as many as we can of those before the end of the presentation. Also, there is no CE, just a reminder, there's no CE offered for our webinar today. And I think we've got pretty much everyone in, Jim. I'm excited to introduce you. Let's dive in and get started. So please join me in welcoming Dr. Jim DiMarino.
Jacqueline, thank you so much for inviting me here today. I'm excited to be with you. I don't want anybody to be disappointed, although you're not going to get CEs, you're going to get a wealth of knowledge. And if you stay through the end of this presentation, you could win a 1-year subscription to our Code Advisor. And some of you may not know what that is, but you're going to learn today. And essentially, what we're going to do is dig into some important topics here that center around bone loss and scaling and root planing. So, who am I and why am I here today presenting? Well, first, we're always going to start with a disclaimer, right? We are not lawyers, so we're going to give you some information that's going to be used to help your practice grow and help you overcome some of those nasty claim denials, right? So, but we don't give legal advice. So, if you have any legal or tax questions, please consult the appropriate subject matter experts and lawyers so that you can get those questions answered. When it comes to coding, you're in the right place. So, who am I? As Jacqueline mentioned, here's a little bit about who I am. Um, just to let you know, I used to work for a dental insurance company. Now, don't hate me, okay? But I did work for dental insurance companies for a number of years, and I was one of those that deny claims. Okay, I said it. Full disclosure, I'm coming out. I have some, I have to own up to that. But I want to teach you what insurance companies are looking for when they deny claims. And I guess the question that I want you all to ask yourselves is, have you seen an increase in claim denials? And especially with certain areas in your dental practice. So we're going to touch on one of those areas today, but this is who I am. If you want to get in touch with me, scan this QR code and that'll put my contact into your phone so you can reach out to me. I just want to share with you that we started raising seeing eye puppies when my daughter was 8. And we thought we were raising one, we've wound up raising 7. And our last seeing eye puppy, Gabble, we get them when they're about 8 weeks old. And we raise them, we train them as a family, and we go to meetings every month, and there's events that you have to take them to so that they kind of get conditioned to uh, for the public, right? So they used to be raised on a farm and they used to be skittish around cars and motorcycles and things. So they worked with the Seeing Eye out of North Jersey, worked with the 4-H club, and now they have these families raising the puppies. So Gavel just recently got placed with a blind person. Now, this is the first time we've raised a Seeing Eye dog that's gone international. So he is actually in Vancouver. All the other puppies are in, well, dogs now are in the United States. And not only is Gavel in Vancouver, he took a trip overseas to Europe with his blind person. So sounds like Gavel was a winner, and he's doing a great job out there. And we're so proud of Gavel and the 7 others that we've raised. But we won't be raising any more seeing eye dogs, just to let you know, because we have a new addition to the family. We have a grandson, and he was born on my birthday. Thank you so much for doing that. Very important and very special birthday present. Nice coincidence, but very welcome. So this is Colton. His father's a police officer in a SWAT division as well. So Colton's in training. He's 8 months old now, and who knows what his future is going to hold, but we sure love holding him. So just want to give you a little bit about myself. So why are we here today? What we're here today to talk about is a crack in the revenue cycle pipeline. Now, a lot of you may have seen this. It's a common phrase that we're seeing in the industry right now. And we know that the cracks are there, but what we're trying to do is help you understand how to avoid some of these cracks and pitfalls. So as was mentioned, we're part of the eAssist family. So proud to be a part of that family. eAssist does dental billing for so many offices. We're the coding side of dental of eAssist and the dental billing. Dr. James Anderson purchased Dr. Blair's company, Practice Booster, and we not only help dental offices across the country, but we're also supporting the team that supports the eAssist billing, dental billing team that helps to process those claims. So where do we see these gaps and cracks in the billing cycle? Well, they're all throughout the process from patient scheduling until the balance is collected from the patient. But where's the code set? Where's the sweet spot for the code set? And that's kind of why we identified this rectangular area here. When the patient's seen for diagnosis, the right diagnoses codes or the right procedure codes have to be captured, but also the right documentation and the right narratives. Because if we don't agree that we're capturing those things at the date of service, then everything downstream or down the pipeline from here is in jeopardy. Just like if the insurance verification wasn't done correctly, just like if they call to schedule an appointment and the phone rings for 20 minutes, right? All those things can affect the relationship that you have with the patient. And a lot of times, if they participate with insurance companies, with the payer as well. So one of the things we ask when we're in person is, how many of you have ever had a crack in your windshield? And what do we know about a crack in the windshield? Does it ever heal itself, right? It tends to get bigger, right? So if we find a crack in this pipeline early on and we don't address it, it can really become a big problem as we go downstream. So we're going to focus on finding the right procedure codes at the right time during a diagnostic process on the date of service so that when this flows through the pipeline, the patient copay can be collected, claim sent correctly, claim followed up for payment. All those things downstream give you the best chance of getting this claim auto adjudicated. So one of the things that we want to talk about are the most common coding errors and where they come from. So we've known that misuse of nomenclature or descriptors is one of the primary causes of coding errors. In addition to that, incorrect arch quadrants for procedures, as we're going to mention with scaling and route planning, this is pivotal and critical. The incorrect age definition, use of deleted or custom codes, outdated coding resources. So all of these kind of bubble up as cracks in that windshield that can affect the downstream efficacy of your practice receiving payment in a timely manner. So what we're going to do is try and make this fun. Now, how many of you are worried about AI? Now, I'm going to try and figure out if I can see any responses here. Let's see. Um, if I don't see anything, I can't see responses. So we're going to wing this. Maybe I can do it under Q&A. I was hoping to see if anybody raised their hand. So I'm going to imagine that somebody out there, of the 186 people on this call, or however many we have, somebody said, I'm worried about AI. Well, I'm here to tell you that AI can be beneficial in many ways for you and your practice. And I understand the concern. So as I mentioned, I used to be a claims processor, a dental director for a dental insurance company a state dental director, then became a national dental director. So during that time frame, AI started to pop up on our radar. We welcomed it in because insurance companies want to pay you. I know this is going to sound strange, so I hope you're sitting down. But insurance companies want to pay you the first time they see a claim if they in fact are going to eventually pay that claim. And I know what we hear. We always hear that, oh, well, insurance companies just want to hold on to my money. They like making the interest on the payments they would have been paying me. Pay me what you owe me. I've had a lot of people yell at me over the years. But what I found and what I want to share is if we get this right at the beginning, your chances of getting that claim auto adjudicated, which means it comes into the payer and the payer processes it and payment goes out. That's the goal. Insurance companies want that as well as we do. Now, I'm a dentist from New Jersey, and when I submit claims, I want that paid as quickly as possible. But to do that, I have to understand AI because AI is really becoming a part of the payer review process. And what I mean by that is the AI just, now it's a more effective way and efficient way of reviewing those claims. And if you know what they're looking for, you can actually place those, get the correct documentation, the narratives, and the attachments on the data service so that that claim sails through. Now, if you stay with me to the end, I'm going to give you a narrative that has proven to help in your perio maintenance program increase claims auto adjudication. That's right. You're going to get it. You're going to get it from us today, courtesy of eAssist and Practice Booster, teaming up to help you in your practice. So, what I found is sometimes at this point in a presentation, especially talking about codes, I get a little tired, and I'm sure some of you might. So I'm going to offer a prize. I didn't say bribe. No one heard bribe. I said prize to stay awake during the rest of this presentation. So what we're going to do is play a little game. So I'm going to switch screens here real quick. We're going to go over here and we're now going to play a game called Kahoot. Now, this game called Kahoot is a great way for us to learn in a fun way, but also to help you win a prize. So, what I would love for you to do if you'd like to participate, again, no obligation. If you scan this QR code or go to Kahootit, go to www.kahootit, you got it. Just type your name in. Now, I beg you, this is a G-rated program. I've had times where I couldn't give the winner an award because they chose maybe a PG-13 name associated with their entry. Unfortunately, that is really hard to promote on social media and against common courtesies, right? So be creative, be fun, have a good time putting your name in here. I'm going to attach a fun, just random icon to you. So I hope it makes you laugh. That's the goal. The goal of Kahoot is to get the correct answer the fastest. So if, say, Bonnie and I get the answer we had the same answer, we get it right, but Bonnie answered before me, or if she was the first one to answer, she would get more points than everybody else. So it's a little bit of gamesmanship here. You got to make sure that you know the right answer, first of all, and then you secure the right answer as quickly as possible. So I'm going to give everybody a little bit more time to log in here. What we're going to be doing during this Kahoot is you're going to be learning about bone loss. I said it. I know it's a difficult thing to understand because it feels like the rules have been changing. So I wish I could see your faces, but many people have told us, and we've experienced this in practice as well, that recently we're getting more questioning from the insurance companies about scaling and root planing claims. So we're going to talk about that today. There's other ones like build-ups. There's so many that we could talk about. And our goal at Practice Booster is helping you to overcome those challenges. Now, what eAssist does is eAssist helps take that pressure off of you. So if you're running into a situation where your team doesn't have the time to provide the quality of care to your patients that they deserve, then looking into what eAssist offers at dentalbilling.com might be a great opportunity for you. I wish I had that when I started practicing. I will tell you, I've been practicing for 30 years. I can't believe it. Oh, stop. No, you guys are too nice. Who said that I don't look like I'm 105? That was really nice of you. I take that to heart. Thank you for thinking that way. But no, I am. I'm a little older than well, I have aged, right? So, but back in the day, it would have been a really nice thing to have on as a backup because these are professional dental billers that this is what they do. Now, what it does is it helps your team have more time with your patients. So just keep that in mind as we go through this presentation. I'm going to get started here. So we only have a certain amount of time. Apologize if you haven't been able to join in yet. Having said that, I'll give you a couple more seconds as it seems like a couple more are jumping in. All right, let's get started. Now, the first couple of questions are going to be a poll question. This is for practice. This is for us just to kind of get a better understanding of what you guys are used to here. Now, that was interesting. All right, so a periodic oral evaluation on an established patient is reported using, you know what? I can't believe I did this. I think this is the wrong presentation, but we're going to go with it. We're going with it. All right, we're going to get this done. We're going to just have fun and have a good time here. All right, let's see what we come up with. All right, we got about 92 answers, 93 answers. I'm going to give you another 2 or 3 seconds. Get that locked in. All right. The answer is a 0120. Boy, okay. All right, we got professionals in the crowd today. Appreciate that. It's always nice to know that we've got so many people who know their stuff here. So Ola answered the fastest with the correct answer. So we're on good trend here. Comprehensive oral evaluation on an established patient is reported using which code? All right. Give you a couple of minutes here. Can't copy the QR code. What's the code? Oh, sorry. All right, so let's see. I'm sure we got a lot answered here correctly. D0150. Again, congratulations. Let's see how that affects our leaderboard. All right, little change on the top line there. Now, I forgot to tell you what you're playing for in depth, but we'll get to that next. How do you think most providers rated their experience with payers on a scale of 0 to 10? How do you honestly feel about your dental insurance carriers? Would you rather do a full mouth root canal with no anesthetic? We fight a lot, but I can't quit them? It's like flossing. I don't love it, but I do participate with insurance. All right. Yeah, okay. So this is it's a very interesting that you said that. 38% when we ran a poll of about 1,000, we ran a poll with a lot of several general dentists, a good number of general dentists, and that was what they mostly felt that the relationship with the insurance carriers is pretty low. It's a 0 or 2 rather than the 10. So a little, not too much love, but we understand that there's a relationship that we're going to manage. So next question. How long do providers say they're on hold with carriers? So again, we polled several hundred dentists, dental offices. How long do you think they answered that they're on hold with providers? I'm sorry, with payers. They're calling the insurance company. All right. Now, one of the questions was one of the answers I got was I'm still on hold, right? So that was a great response, but that's not on this question here. So we found on average that it's about 16 to 30 minutes. Now we see that as an improvement. Not too long ago, it was upwards of 31 to 60 minutes and truthfully over 60 minutes. So that's why we took the over 60 minutes off this time. So let's see how we're doing. Claire is on top. Now, the winner, as I mentioned, gets a 12-month subscription to Code Advisor, which is the online version of our Practice Boosters Dental Coding with Confidence. Brand new release. We've just updated the website. This is how you can look up codes and understand more, get more information on how to properly code. So I wanted to make sure I put that out there, let you know what you're going to win. It's usually $49 a month. You're going to get 12 months for free. All right, let's go to the next question. How often do providers say insurance payments are delayed? Every time? Almost every time. Frequently, not very often. We've been hearing this a lot from our our, our providers out there. It's very difficult to get sometimes the answers that you need, and sometimes the claims are delayed, and you have to make that phone call. So you are correct. frequently, number one answer, yes. Good choice in answers. Let's see if that shook up the leaderboard here. Claire's still there on top, staying strong. Well done, Claire. All right, next question. Halfway through, what's the top issue caused by long insurance hold times for your office? Is it productivity lost to hold music? Morale melts like ice cream? Patients rescheduled from delays? Teeth fix themselves while you're waiting? How does this impact your practice? How do these times on these phone calls waiting for insurance carriers affect your practice? All right, we got 91 answers so far. Let's get the last couple. Okay. You're right. So again, majority of you got it. You lose productivity while you're waiting on hold. And why are we waiting on hold? Because there's something wrong with the pipeline. Something happened throughout the process that claim was denied. So we're going to talk about how to fix that today, but we really want to set the baseline here of what everybody's experiencing. And this is a little harder to get the right answer. I understand. That's why this is a very valuable giveaway. So we got Monica rising to the top here, new leader. Let's go to question 7. Which carrier benefit did providers say helps them the most? So when you're calling off dental carriers, you're calling your insurance company saying, hey, I need help. What we're trying to establish is what can the dental provider give you that's going to be most helpful? And I think most of you will get this one right as well. That's my hope. All right, almost done. Looking for 92, 93. We got 98. Okay, you did. Supportive reps. Now, some insurance carriers have them, some don't. But that plays a big factor into your practice. As you know, similarly, when dental patients come to your practice, it seems to me and to us that that connection between your practice and your team or your patient and your team is the most critical. So just like when you call the insurance company, you want somebody on the phone. You don't want to talk to a bot, right? You want to talk to somebody. When their patients are coming to your practice, if they've got a question or a concern or just want to say hi before their visit, they want to talk to you. And that's why this is so critical. And that's why it's another place that eAssist can help give you more time to talk to your patients and let them take care of some of the other busy work that takes so much of your time. So, Dawn, I love it. All right, let's go to question 8. We're coming down to the end. What's the top frustration most providers have with dental insurance? Bad customer support, policies written in visible ink, claim delays or denied, payment rates stuck in the 70s. So this is what I heard a lot when I was a dental director. But what we want to do is give you the tips and tricks so that you can avoid having to reach out to the dental insurance carriers. Or when you do, it's really for a focused reason and it's a reduced amount of times that you have to make this call. All right. Wow. Payment rates stuck in the 80s. It's interesting. Claim delays or denied. Now that is the number 2. But when you think about the 2, a lot of times providers are concerned that the rates that they reimburse at are low. And then they also deny it. So they go hand in hand. I can see why so many picked the claim delays or denials. So it might shake things up there. I know it's not an easy one for sure. All right, let's go. Erica, new leader. Question 9. We're getting into some double points now so we can make up the difference. Which answer did most providers choose when asked? On a scale of 1 to 10, how well does insurance support your practice? So what resources do insurance companies give you so that you feel supported so that you can submit your claims and get them paid? And the reason this is so important again is I'm going to teach you some of the things today to get through the insurance roadblocks. All right, we had 30 and 33 again, neck and neck. It's really hard, I know. Well done. Let's see what happened here. Erica's staying strong. We're going into the final 2 questions. All right, double points again. What did providers say could be bet? What did providers say payers could do better? Do you want faster rep responses, more provider training, clearer claim denials policies, dedicated office liaisons? Now, insurance companies have been trying to do this and they offer you certain things. The challenge is, has it really helped your practice? And what we're going to get to in just a few minutes here is the solid recommendations that are going to help you bypass a lot of these obstacles. All right, let's see. Clear claim denials policies. Again, you guys are definitely getting the number two and the number one responses. Faster rep responses also coincides with us as providers helping our patients, making sure they get the responses they need from us, just like we have to get those responses from the payer. So it does kind of come together there. Wow, Davis is now on top. We're going into the final. Let's see, two questions. Okay, how many CDT code changes have there been from 2020 through 2025? Why is this important? Because when the codes change, your billing practices and your dental offices have to be made aware. Otherwise, you could be submitting claims incorrectly. And the easiest way that we could help you get claims paid correctly, that's amazing. Okay, so has anybody taken this course before? You guys are super smart. 249 is the answer. So well done there. I think that's going to help get some people back on the leaderboard. There's Erica. Erica, Magnolia Smiles, Davis, Dawn, and Callie, you're competing for the final question and the final prize. Let's see what question you're going to get. How many CDT code changes are coming in 2026? Right around the corner. There's been 249 changes in the last 5 years. How many are there coming in 2026? Now, the winner of this isn't going to have to worry because you're going to get Practice Boosters Code Advisor. All the changes are going to be there for you, and you're going to be able to look them up on your computers in your office. Now, there's tough one, and 22 got it right. That's impressive. 60 code changes coming in 2026. So one of the things we talked about was making sure you update your coding resources. If you've got a book that says 2012, 2015, 2018, anything before 2020, we just mentioned 249 changes in from 2020 to 2025. Now there's 60 changes next year. That's 309 changes in the since 2020. So those items could be obsolete and that could be causing delays and denials for your practice. Okay, without further ado, let's see who our winner is. We're going to give you a third choice. Davis is in third place. Davis, thank you. Magnolia Smiles in second. And who could this be? Erica. Erica, you are the winner of a 1 year subscription to Code Advisor. So, Erica, I'm going to need you to make sure you stay on this call and don't leave because we need to get your contact information so that we can send you the complimentary subscription to Code Advisor. I'm going to take a quick picture here so I have it recorded. I want to thank you all for your patience. Erica, I want to show you what you just won. So, Erica, this is Code Advisor. This is our online platform that's going to help you get your claims paid faster. So if you type, you can either type a word in here, you can type a code in here. So if I type SRP and then I come over here and I click the word search, it's going to search all of the codes for SRP and see what comes up. So let's click search and there you go. You got periodontal scaling and root planing, 4341, 2. What's a 4910? We're going to talk about that. And a 9910. That's interesting. We might want to look into that one. So what if I didn't know? What if I just wanted to look up, I don't know, let's pick another term. How about gingivitis? What if we have a gingivitis issue and we want to know what's going on there? And I don't know which code to use if a patient's got gingivitis. I click search. Well, there's only two choices if I got gingivitis. One, if it's more than 30% of the teeth, then it's a D4346. If it's less, it's a 111, it's a 1110. If I click on this code, it's going to open up and it's going to show me everything that's in the ADA CDT book is right here. Then we go into warnings, when to use this code, when it might be more appropriate to use a 1110. And if I click on this, I don't know what that code is. It'll tell me what it is. If I want to view it, I click here and I go right to it. It gives me watches, matches, comments. It tells me what the frequency and limitations are from carriers. It gives me narratives. But I love this part. Look at this flow chart. It gives you a flow chart that you can use with your practice at your next staff meeting to say, let's get on the same page. So this is what you just won. I'm so excited for you. Now, anybody who else stays on till the end, we can't give you the same present, the same gift, but you stay on through the end, we're going to give you a special offer as well to enjoy this wonderful benefit. So excited and grateful for the time you guys took. Now, that's only part of what you get with this subscription. There's newsletters. Every other month, we come out with these beautiful newsletters that take all the questions that we get asked during the year, during the first 2 months, and we compile them into the insurance newsletter. We've got Dr. Greg Grobmeyer, we've got Dr. Brad, we've got Tiffany, we've got Amra, we've got Julie, Denise, Mason. We've got a full team here, Amanda, all helping us build these documents for you. You can see that this is the July, August, and it talks about the sneak peek for the 2026 code changes. This also gets mailed to your house if you sign up for the subscription. So a lot of things in here. We've got podcasts, we've got other resources where you can download certain things. So there's all that information. Let's get back to our presentation and let's get into the meat of what we're going to be talking about today. The number one denied and appealed code is the scaling and route planning codes. So it's really important that you track with me here because I'm going to give you really specific information on how to get these claims paid first pass. So let's dig into this. So scaling and route planning procedures are often face the highest denial rates. Now, part of that, many of us think is because of AI, and you're right. It could be now, or it could be our documentation, or a combination thereof. This is what's critical. I'm glad you're still here because this is what's going to make the difference for your practice. 30% of payers are currently using AI. 56% are going to use it. 21% are using it in other areas of claim processing, and 50 are planning on implementing it. 75% of electronic claims and 50% of paper claims are auto adjudicated. You see the reduction for paper. So if you're still submitting paper claims, good idea to maybe consider switching because it's much more difficult for the dental payer to process a paper claim than it is an electronic claim. So why is this important? Because if you give the algorithm what it is looking for, there's a greater chance you're going to get it paid. And if you do it electronically, you're going to get it paid quicker. And most of the time on first pass. So let's establish the baseline. Got a healthy tooth on the left. Healthy tooth means there's no bone loss and there's no inflammation. On the right, periodontitis, you have to have bone loss. So that's the first critical statement on the periodontitis. So let's walk through this. The criteria required to process claims for a 4341. If we understand this up front in that pipeline and we capture the information and we assess the patient correctly, get the documentation, the radiographs, the charting, then we're going to set yourself up to make sure that this claim gets paid first pass. First thing, requirements for 4341, 4+ millimeter probing depths, bleeding upon probing, recession, frication involvement, and/or tooth mobility current within 12 months of the procedure. The documentation details the patient's condition diagnosis and treatment plan, typically paid once every 24 to 36 months. When performing on 2+ quadrants, include comprehensive documentation to justify the extensive treatment and that bilateral mandibular blocks were not administered. This is the supporting documentation. You know you're in a scientifically based presentation when you see references that are verifiable and don't say Wikipedia. Okay, so this is a very important screenshot to remember, but diagnostic quality radiographs have to demonstrate bone loss. I will tell you, a pan is non-diagnostic for bone loss in most cases. So if you're taking a pan, you might want to consider bite wings. Full mouth series with bite wings included also helps increase your chances of getting claims paid. All right. The question then becomes, well, how much bone loss is required to get reimbursed for 43, 41, or 2? I'm glad you asked. So let's look at the science. There's research out there that had that same question. The conclusion was a distance of zero point 0.4 to 1.9 millimeters is consistent with no bone loss. So when we look at something, and what I'm going to share with you is some of the things that I've been challenged by practitioners. How can you dictate treatment? You've never seen my patient. They need this. How come are you even a licensed dentist? All those things, I understand why we're upset and frustrated, but they don't help you get this claim paid. What we have to do is calibrate. So what we're saying is if it's less than 2 millimeters if it looks like there's less than 2 millimeters of bone loss, the research has established that's not consistent with pathology. It has to be 2 millimeters or more. So let's look at our references again. The health was defined as less than 2 millimeters of radiographic bone height. So when you look at something on an x-ray, it's sometimes very difficult to know if you're at 1.9 or 2 millimeters of bone loss. In fact, it can be impossible. Depending on the angulation, there's a lot of factors. So what we have to do is calibrate our mind to understand what bone loss looks like. So let's look at what the definition would be. Visible radiographic bone loss, 2 millimeters or more. And the key is you measure the distance between the CEJ and the alveolar crest of bone. And why is that so important? Because now we're looking at the bone loss in this plane, not the vertical dimension that a lot of people look at. And I'll show you what that looks like on an x-ray. So why 2 millimeters or more bone loss are required to get approved for a scaling root planing? In the name scaling and root planing is the word root and planing. So if the epithelial attachment is at the CEJ or close to it, that means there's no real root exposed to plane. So if you look at this on the left-hand side, this is supragingival, and the neck of the gum is attaching close to the CEJ. So the root actually isn't exposed. So if there's no root exposure, you can't plane the root. And that's something that I guess I thought was intuitive when I was going through dental school, but when I came into practice, I kind of lost that track and I kind of started misjudging myself. So let's look at that. Otherwise, you can't get the instruments to the root to actually plane it. So quiz number 1, is there 2 millimeter bone loss in this x-ray? So take a piece of paper out. I'm going to do it myself and write down number 1 and just say yes or no. All right, so 1. All right, next. Do we see what we want to see or hear what we want to hear? Now, why do I say that? Because I can look at this, and this is x-ray number 2. I can talk myself into 2 millimeters here. I think. I don't know what 2 millimeters is because I don't have anything that's relative. I don't have something that I can look at as a scale. So do you think there's bone loss of 2 millimeters or greater in this bite wing? So this is question number 2. Write yes or no. And now let's go to question number 3. Is there 2 or plus millimeters of bone loss in this bite wing? So I just want you to look at it now, and then we're going to kind of look at it through a different lens to see if this is going to help you calibrate. All right, so how do we calculate bone loss? We're going to get back to those 3 answers, but it's kind of a cliffhanger. I know you're on the edge of your seat. We're going to get to it, but let's talk about how we calculate bone loss. The first thing we need to do is define where the CEJ is, right? Where the cemento-enamel junction is. So if we look at the mesial of tooth number 3 here, distal of tooth number 4, I can see the enamel and I can see it thinning coming down to that perpendicular, that triangular design. And I say, okay, that's kind of where the CEJ is, where the cementum, which covers the root surface, meets the enamel, which covers the coronal portion of the tooth. All right, that's step number 1. Now, what we're going to do is connect the lines. So you want to draw a line. Now, this one's a little difficult, right? Sometimes you're going to lose the most distal of the teeth because of the angulation in the arch, right? So we're going to try and get as many as we can. We're going to lose that one. We're going to lose this one, but you get the idea, and it's not that critical. So the idea is we're going to draw a line through that CEJ, there, boom, got it. And we're going to be a little off there, no worries. And again, you're going to see how this all comes together in just a minute. Same thing here, just try and get as close as you can. All right, next step, draw another line at the height of the crest of bone. Again, it's not going to be perfect, but you get as close as you can and try and divide the difference. Like this one matches here, that one's a little higher. This one's a little lower, a little higher, a little lower. Typical. Don't worry about that. Just kind of get close. All right. Now, once you do that, now, okay, so now we've established that that's the distance of bone loss, or that's in question. Okay, so now what's the next step? How do we calculate 2 millimeters or more since we don't have anything that we can use as a scale? Now, AI, different story. We could talk about that all day. But in most cases, this is what we're going to be looking at. So I offer that on average, the mesial-distal width of the maxillary second premolar is around 7 millimeters. So mesial-distal width is about 7 millimeters. Okay. So if we say from there to there is 7 millimeters, and I divide that by 3, that means the distance between each of these is about 2.33. And I think we can agree that 2.33 millimeters is greater than 2 millimeters. Again, not you don't need to get a caliper out. This is once you see it, you're not going to be able to unsee it. So let's just go through this exercise and just stay with me here. So now what we're going to do is we're going to measure that distance, right? And now what we're going to say is, okay, each of those blue arrows is 2.3 millimeters in distance. If I can move those arrows up in between the CEJ and the crest of bone, same thing down here, and then I put my lines back and those lines don't touch, I'm pretty confident that that's over 2 millimeters of bone loss. So for all of you who answered question 3 with a yes, take a look at your notes. If you said yes on number 3, you are correct. Stay with me till the end. You're going to get a special prize. Really excited that you got that right. Now, what are we really measuring? We're measuring the distance between the alveolar crest of bone, the height of bone, and where the CEJ is. In a healthy gum, that blue line will hit, the blue arrow will hit those lines, one of those lines, because there's not over 2 millimeters of bone loss. But once you start getting bone loss, that opens the space up. And now the blue arrows won't touch those lines. So I'm hoping this is starting to sink in. And I definitely take questions at the end, but I want to make sure I get through this. Um, so let's look at this one. Now, let's put your hats on and say, okay, is there 2 millimeter bone loss here? Well, I think you may already be starting to see those, imaginary lines. Again, you don't have to go and spend, if you measure it once or twice, that'll probably be the last time you have to do it. Then you're going to start to understand that, okay, I'm pretty close. So I just kind of fast forward this for you. And I took the measurements, and the blue arrow is hitting one or both of those lines, not bone loss. So how many of us would have submitted this as a 43, 43, 41, or 42? Because sometimes, a lot of times, people will say, I'm going to measure from here to there. And that's way more than 2 millimeters. And then I look here, I'm like, oh, that's 2 millimeters. And I think, okay, I get what you're saying. But when you draw those lines and you connect them, there's bone here, there's bone there. That's not a true vertical lesion, right? So what we're looking at is what the AI is looking at, and now we're going to calibrate. So the question is, to be or not to be, was the question that was asked of us a long time ago, and Shakespeare was famous for that. Now, what we're going to do, and we kind of made this a little fun, Dr. Blair says to appeal or not to appeal. That's the question that we want to help you with today. We want to help you get this understanding of what the AI or insurance companies, if they don't have AI, are looking for, so that if you get a denial, you know whether to pursue the appeal. One of the things we hear a lot is that, oh, well, I tried to get this scaling roof planing approved. I sent them all kinds of documentation. They denied it. I sent them more documentation. They still denied it. I appealed again. I asked for a peer-to-peer. The problem is, if they were never going to pay for this because there's no bone loss, then there's no real solid foundation for an overturn of the appeal. So we want you to be very critical when you submit for the scaling of roof planes to know, do I feel confident if this gets denied that I'm going to appeal it? And if we are, then let's put everything we can into the initial submission so that we can avoid the denial. Okay? So the challenge with appeals is 75% of the claims that are denied are for administrative reasons, not clinical. That means only 8% are denied due to clinical insufficiency. So your chances of getting an appealed claim, a denied claim through on appeal, unless it's administrative, wrong birthday, wrong social, wrong whatever that, that side looks like. If it's clinical, your chances go down, significantly, but there's times when you definitely want to stand by your appeals. So that the one thing I want to share with you, and you already know this, is the decision from the insurance carrier is a benefit determination. It's not a treatment recommendation. So as much as we want to call that dental director and we want to lay into him or her and say, I know you're not even a real dentist. You probably don't even have a license in my state. You probably don't even know which tooth number 4 is. I've heard them all. Let's talk about what we can do on our side to just avoid all that. So I'm going to ask on that left side, I apologize, it's a little fuzzy, but I wanted to get the bone loss aspect. Do you think this should you appeal this if you submitted for a 4341 on the left and it was denied, would you appeal it? So this is question number 4. So write down yes or no. So I guess, yeah, yes, if you want to appeal it. And then let's look at this one. If the right one were denied, would you appeal that one? So that's question number 6. I'm sorry, that's question number 5. So would you appeal the one on the left is question number 4, yes or no? Would you appeal the one on the right if it got denied, yes or no? Okay, so when in doubt, draw it out. First thing I'm going to do is the red line connects the CEJ, the yellow line connects the bone height, and I'm going to do the both on both sides. What I want you to see right away, it's going to be pretty evident once you start drawing these lines. If there's no bone loss, you get a clean look. And the lines look like railroad tracks. So railroad tracks usually means no bone loss. Not always, but usually. Hills and valleys, bone loss. Like when you look this disjointed, it kind of you probably know that it was bone loss. Now let me go back and just go to this view. Now having said that, when you looked at this left one initially, I should have asked you before I did this whole thing if they thought that was if there was bone loss there. So now when you look at these, it's pretty clear that without even drawing the lines now, you can start to see that there's bone loss here. That's pretty dramatic, but this is the one typically that people have been, this one got appealed 3 times. So we have a product called revenue enhancement where we work with dental offices. And we look at your fees. The first thing we do is we tell you where your fees are for your area. Usually what we find is you're at the either 65th to 68th percentile of fees for your area, meaning that there's, the other dentists in your zip code are most likely billing out higher than you are for your fees. And that's something that we calibrate for you. So we'll give you the 75th, the 85th, and the 95th percentile for your area, and you decide where you want to put your fees. And what we found is most offices could generate, now legal tells us we're only allowed to say $25,000 in increased revenue by just doing a fee analysis. In truth, it seems to be a lot more, but you didn't hear that from me. But what I can tell you is you're going to see it about 25,000 or more of increased revenue by just getting your fees to the level that's appropriate for your area. Now, as a dental director, I would gladly pay you $100 for a quadrant of scaling root planing. 100%. But you don't know that I'm actually paying your neighbor or the dentist across the street $200 or $300 because you haven't raised your fees. So if you're getting close to your reimbursement level, your UCR fee and your reimbursement level are close, chances are you want to reimburse your fees, increase your fees. But the bottom line is you should get it evaluated. What we see is a lot of offices leave so much money on the table because they don't update their fees every year. And what they tell us in this case is, I can't get this claim paid. Well, this is definitely not one you should appeal. In fact, that even shouldn't, the only thing this could be is a 4346, which is what we're going to talk about next, because that's a very important code that's being underutilized. So when in doubt, draw it out. Railroad tracks typically don't equal bone loss. Hills and valleys, potential bone loss. Now, if you wanted a flow chart that's even more enhanced than the one I shared with you earlier in this presentation, in our 4341 code, in Code Advisor, here's our little Code Advisor friend. I showed you what it looks like when you pull it up. This is the full perio maintenance flow chart. Patient presents, does gross plaque or calculus inhibit an evaluation? If yes, then you're over to the 4355 world. If not, let's talk about it. This is an imperative step that you should be evaluating with your office so that you're not losing any money or undertreating a patient. And it's all right here for you. This chart alone pays for Code Advisor the first time you use it. Think about what your scaling root planning quadrant fee is. If this is, this program is $49 a month, or we're going to give it to you for $479 a year. Quadrant fees are pretty close to that in most cases, or at least 2 or 4. You're going to be at that number pretty quickly. And if you know how to do it correctly, this will pay for itself, and you'll get all 2025 codes and all 2026 codes. This is the perfect time to become a Code Advisor subscriber. So, having said all that, what we're seeing during our revenue enhancement programs that we offer offices is, like I said, at least $25,000 increase by just adjusting your fees appropriately. But then we see offices are underutilizing codes like the gingivitis code 4346. They're trying to get 4341 or 2 approved, when in reality they should be submitting for 4346 because there is no bone loss. And they're not understanding how this kind of all comes together from an AI perspective. So, gingivitis affects 33 to 50% of adults in the United States on at least 3 to 4 teeth. Periodontitis is even higher in some cases. And just something that we have to look at and understand. If you're not billing out for a D0180, here's what I'd like you to do next. Write down number 6. Look up how often you billed out D0180 for last year, and then how often you billed out 4346 last year. If those numbers are either 0 or pretty low compared to your patient population, then you need to call us so that we can help you do a revenue enhancement and get significant money back into your practice while you're coding correctly. Because here's the trouble. If you're continuing to treat gingivitis and periodontal patients as a normal prophy, you're telling them that they don't have periodontal disease. And if they do have periodontal disease in some fashion, whether it's gingivitis or periodontal bone loss, then you have to tell them that, and your clinical record will support those statements based on the diagnosis and the treatment rendered. So check 180 and 4346 for the year. What I want to share with you is, if a patient does not qualify for the 2 millimeters or more of bone loss, but they have a lot of bleeding, and your hygienists are complaining of a dirty prophy or a difficult prophy. My wife's a hygienist, love her dearly. Problem is, these are not normal cleanings. That's why 4346 was entered into the CDT code set, so that we could capture the in-between patients that are in between a regular prophy and don't quite have bone loss or periodontal disease. So what are we looking for? You have to have 4 millimeter probing depths and or bleeding upon probing on greater than 30% of the teeth, but there's no bone loss. So when you look at those x-rays that I showed you earlier, and you're like, now I kind of see that there might not be bone loss, you can always submit for the scaling and root planing if you're going to do a predetermination, and then say, if we don't, if it doesn't qualify, then consider the 43, 46. But the challenge is if the bone loss isn't there, the scaling root planing won't get paid. And then you're going to have to resubmit that claim or appeal it and say, well, at least give me the 43, 46 because, and I'm going to give you the narrative. Stay with me. The narrative is going to change your life. And it's a couple slides away. So first thing we need to do is count how many teeth have 4 millimeter probing depths or bleeding upon probing. And if one of the 6-point periodontal probing is a bleeding point, then that counts as one for that tooth. Similarly, if one of the 6 points is a 4, then that counts towards your total. So in this case, we've got a 4 and we've got bleeding, so that counts. We've got 4 and bleeding, that counts. We've got a 4 and bleeding, that counts. 4 and bleeding here, that counts. Again, 4 bleeding, 5 bleeding, 4 bleeding. So the question then becomes, if you didn't have bleeding, but you had a 4, then that counts. So we're counting up how many teeth have either a 4+ millimeter probing depths and or bleeding upon probing. If they have it, then they qualify for the 43, 46. So here's the big finish. Here's why you wanted to stay on so long. Here is your narrative. The narratives, as you know, I hope, have to be at least 80 characters or less. 80 characters includes spaces, punctuation, exclamation points. 4 millimeter probing depths and or bleeding upon probing on 30% of teeth with no radiographic bone loss. That's what you put into the remarks section of the claim form. So how many characters is it? 77. That passes. If it was 84, well, the last 4 would not be counted. The spacing and punctuation count. Yep. Now, how do we customize this for each patient? We calculate the number of affected teeth divided by the total teeth. So let's just say there's 9 affected teeth. So 9 teeth have either I said, 4 millimeter or more probing depths or bleeding, right? We count them up, we divide by 28, that's 32, that's greater than 30. So I would change this and say for this patient, 4 millimeter probing depths and or bleeding upon probing on 32% of teeth. And that's the only thing I would change for patients going forward. That is your narrative. This is the most critical thing we could have shared with you today. If you identify that there's no bone loss based on these new, or maybe, this realignment of how you're going to assess bone loss, then 4346 is probably the next code you want to consider if it meets these criteria. So just to give you an idea, we completed a we completed a revenue enhancement for this client. They were never using 4346. So what we identified is that there were about 374 patients who may have qualified for 4346. Because they didn't do it, they left 60,000, anywhere from 40 to $60,000 on the table because they didn't understand the 4346 code. Now, this may have gotten these claims, they may have submitted these claims as scaling and root planing, and then they got stuck in that denial appeal loophole. But you can't force an insurance company to pay. So if the documentation isn't correct, then pivot from the start by understanding what the patient's true needs are. This is what we do in our revenue enhancement program. If you couple revenue enhancement program with Code Advisor, that could be a game changer for your practice. Not to mention the fact that you could bring eAssist in there also to help with all of these concerns. And now you've really taken the time to put more into your practice and your patients rather than trying to manage all these other things. So if you're interested in learning more about our revenue enhancement program, as I said, we found anywhere from $25,000 to $50,000 on that they're leaving on the table. And what we're saying is that they're coding incorrectly. They just by coding correctly, they could increase their revenue by $25,000 to $50,000. So you're not seeing more patients, you're not doing more procedures, you're just getting paid what you're rightfully owed. This is a QR code. If you're interested, scan that and we can help you. So the price of this is $24.99, $2,499. You also get a subscription to Code Advisor, which is included, and you also get 3 hours with one of our revenue enhancement advisors, Dr. Greg Grobemeyer. We've done over 3,000 practices over the last 2 decades with Dr. Blair pioneering this. And what we'll share with you is what your fees should be set at, what if you're using deleted codes, which codes to use instead. If you're using custom codes, which codes to be used instead, because deleted and custom codes submitted to insurance carriers will result in claim denials. And then we'll look where you're underutilizing codes like a D0180, a 4346, and many others to see where you can increase your revenue potential. So there's Dr. Greg. You also get the Dental Administration with Confidence book. You get the online code advisor. You get the newsletter. You get a 2.5 hour to 3 hour consultation with a Dr. Greg or another advisor. And you also get 3 hours of CE. So revenue enhancement is a great option for your practice to get back in alignment, ask any questions that you may have, but really understand that code set. So I really want to say thank you for joining. Now, just for all of those who stayed with us till the end, we're going to give you a special coupon so that you can get Code Advisor free for 1 month. You don't have to pay anything. You can go kick the tires, put in your favorite codes, try and trick it, put in Maryland, see if it comes out with the Maryland bridges. Do whatever you want to actually see how well Code Advisor can help you. And really make sure that you look at that QR code. I'll go back here and scan that if you're interested in having one of our dental dentists and dental advisors help you in your practice. We also have a coordination of benefits training. We also have an aligner training that we can do. All of these are one-on-one coaching with your office. Those who are doing aligners or thinking about doing aligners, we've got a program for you there. We've got coordination of benefits training. We've got just a lot of opportunities here that we can help you. So I know we went over a little bit, 2, 3 minutes, but let's try and look at Q&A and see if we've got anything we can do from the questions. Jacqueline, do we have any questions? I'm trying to pull that up.
We do. We have, well, there's one from Jonathan Sidlowski. He says, what would you recommend when the carrier is denying
Hmm.
D4341 claims because asking for appointment length? Obvious include the appointment length on the claim, but it's not a clinical reason. All clinical documentation is present. They only want the appointment length. There are forums about this as being a hot topic for Aetna claims. Do you have any comments on that?
We're hearing this a lot. Well said, Jacqueline, and it's a shame. And I, unfortunately, sometimes we have to. You're right. You wonder where the clinical requirements are coming from. Um, Especially, one of the things that we see often is if you're doing more than 2 quadrants at a time. Now, there's times to do 4 quadrants or 3 quadrants, but it is a good idea, and I didn't mention it during the presentation, although I hesitated. I think it might be something that's worth documenting in your chart notes. It seems to be something that is becoming more and more apparent. So we have had similar questions in our revenue enhancement programs where we said, you know what, let's just document the time. And usually we have it in your appointment scheduled. You know what time they started, what time they finished, or close to it. But it is something you might want to consider adding to your chart notes. Dr. Greg and our team, we're all looking into this. Tiffany Amra, Dr. Brad, we're all going to try and figure out a little bit more about this. And we'll probably have an article coming out in our insurance newsletter because that is a hot topic. So look at that insurance newsletter for upcoming information and we'll get you some more concrete advice and recommendation. But at the time, we don't want you missing out on the payment. So one of the things we're recommending just for now, at least till we get more information, have your team jot down the start and finish times just so you have it.
That's great. There are a couple of comments on the D4346. Todd Adams says usually gets downgraded for us to a regular pro fee.
That's right. I've seen that. We've seen that too. That's unfortunate. Again, each of the carriers can make their own benefit determination. Now, the challenge with the benefit determination is it comes from what the employer purchases. And this is the thing that is very difficult for me to understand is the employer actually purchases a plan from the carrier, and the carrier can say, well, these are the limitations. And that's why the fees haven't really been increased. So it all kind of comes together. The employer can purchase a higher plan where the 4346 is not downgraded, but in some cases, that is what the employer purchases, and then the payer has to administer that benefit in that fashion. So I don't, And not something that we typically like to see, but it is a typically an employer benefit issue. Um, I would definitely continue to reach out to the payer, and that would be something I would challenge and appeal. And if they just paid you out as the pro fee, then unfortunately, sometimes there's times to fight and sometimes just to say, okay, I accept this and move on. But I wonder if they also add a frequency to that so that now that counts as one of six or two of 12. So those are the things you might want to explore. It's like, okay, well, if you downgrade it to a 1110, do I still get to do another 1110 or a true 1110 when the patient comes in? If I had more time, I'd talk to you about how 4346 is really to help reduce the inflammation so that you can appoint them to come back in 4 to 6 weeks so that you can actually do a prophy and a 1110. So that's why it should be in addition to, not in place of. And theoretically, that could jeopardize the 6 month cleaning that comes up, but that's something you talk to the patient about. We can talk to you more about that if you want through a revenue enhancement.
Also, there's someone asking if you could revisit the narrative slide
Oh,
by
sure. Great question.
Also,
Yeah,
while you're
there you
doing
go.
that, that's great. Bonnie said she's noticed that insurance companies deny the 4346 if a patient has any prior history of periodontal disease.
Bonnie, love that statement. 1,000% correct. So let's go back to what the employer purchased, right? So if, and truthfully, let's go back to the science. If at any point somebody has had bone loss to the extent where they've had periodontal treatment, then a 4346 can't really be on the table because the patient's already has had a previous diagnosis of periodontal disease or bone loss. That's the problem. If you remember, I think I can slide up one more here. Yeah. So the requirement of the 4346 is that there is no evidence, past or current, of bone loss. So if there has been a history of bone loss and or periodontal treatment, the insurance companies will most likely deny a 4346. So chances are you're into a 4910 issue or a retreatment if it's been over 3 years and or 2 or 3 years, depending on the insurance carrier.
Great. So another question is, what's the best way to word if the D 4341, 4342 will not be approved?
Hmm.
Consider a D 4346 down code for appeal slash reconsideration repurpose or purposes.
Love that question. So, um, I don't know if anybody's ever heard the term a pre-appeal, right? So this is a risky thing because if you submit for a scaling and root planing, and I've seen this happen and we've done it, and it can work. And the idea is if you don't agree, like if it's on the margin, this is where we use it, and this is what I can tell you. Everybody's got to make their treatment determination based on their clinical judgment. But if you're looking at that X-ray, Nick, boy, it's so close. I think there's 2 millimeters or more bone loss, but I'm not 1,000% sure. You might say, hey, I'm going to take the chance and submit it as a scaling and root planing as a predetermination, right? Because if you've already done the work, then that's the problem. Because if you've already done the work and there really wasn't bone loss, then you could have done scaling root planing. If there's no plane, root to plane, then really how were you actually treating that patient? So the challenge in a predetermination would be, if let me know, the way I would word it is, if you do not believe, or if the qualifications are met for scaling and root planing, please consider the alternative. Please consider the 4346 as a benefit. It's not an alternate benefit, right? Because I mean, you can get wordy there and you don't want to waste too many characters on it. So that's how I would handle it in a predetermination case, because then you're not locked into one treatment or the other.
Okay, good answer. So there is a question about any AI software recommendations for x-rays or billing claims.
Wow, I love that. So I love AI. I love technology. So there's so many out there. I could go at length on all the different AI vendors out there. Um, don't have an affiliation with any of them. So, I I would say go to your local meeting or have them come in and demonstrate for you. What I look for in my system is something that's very user friendly on the clinician side, because what you'll experience is many of you probably ever done this when you just started getting, digital x-rays. They can see the x-ray, you can take an intraoral photo, and when they hear you call out 4346 and those types of things, and now they see these x-rays pop up and they're already auto, annotated, you're like, it's sometimes very impressive to patients, but it also helps you in the communication process. So find the one that fits you the best. Some have bells and whistles that you might like, and some don't like them because they get a little more complicated in some cases, and some are really easy to use. So go to your local, meeting if you have it, or call the vendors, have them come in and showcase what you will see on your side and what you can use as an educational tool for your patients. That's how I've done it. And I think that's a great way to feel more comfortable with the software that you potentially might be purchasing and then seeing the ROI from it.
That is great. So there is, Emily says, our hygienist has had patients in their 20s with
Mm.
subgingival calc and wants to numb. So she is diagnosing the 4341. Would this be a 4346?
Boy, this is an all-star cast. So one of the things that we do with CodeAdvisor is you're allowed to ask us questions. I forgot to mention that. You can submit questions to us and we'll answer them within, we need some time, sometimes like 4 or 5 business days, but we will answer those questions. We get these questions a lot. The challenge with some of these recommendations, and let me just see if I can find your question, Emily.
It was almost to the end. Let's see.
There it is. Oh, right. So when you get to somebody in their 20s, you have the whole key here is there bone loss? So, Emily, I hope today showed you another way. If you don't have AI, if you have AI, it's a whole different story because AI can map it out for you. But if you don't have AI, this is a good way of seeing this in an analog fashion to determine if there's bone loss. If there's bone loss, age is irrelevant, but insurance companies are less hesitant or more hesitant to approve a scaling or root planing for somebody in their 20s. So you have to have a stronger case. Now, it sounds to me that in your situation, the first thing I would do is take this webinar, go through these slides with your team and your hygienist and say, let's start mapping this out. Now, you can have calculus without bone loss, right? You can have subgingival calculus without bone loss and exposed root surface. And that's typically, I think, where you might be stuck in this kind of a situation. Now, if there is bone loss, it's a no-brainer. You submit that through as a scaling and root planing. If there is no bone loss, then and there's the criteria as we see here, 4+, actually I should say 4+ millimeter probing depths and or bleeding upon probing on 30% of teeth with no radiographic bone loss, then that would support the 4346. And I would call it the calculus at that point as well. Calculus is no different than getting a split finger. The body's reacting to a stimulus and the body's trying to fight it and it can't cause inflammation, bleeding. Those are the things that you put into that narrative. And I would state, although the patient is 20 X years old, we see X amount of bone loss, subgingival calculus, or I'm sorry, no bone loss, but subgingival calculus, or however you say it. You just have to be true to what the condition is, but include the age because that could trigger an automatic denial from some systems if they're not calibrated to really look at the X-ray to see if there is bone loss. I hope that helps, Emily. If not, reach out to us. We can go into more depth.
There's just a couple of questions left. Another one on the D4341. If the benefit determination is downgraded to D4341 to 4342, are in-network providers obligated to adjust the fee to 4342?
Yes, good question. And unfortunately, these are all plan determinations, right? So you can't get around the plan determination. So those are things you have to really look at. And if you can't, sometimes it's difficult to read these EOBs. This is where our COB training would really come into help. Not just COB training, but within our COB training and revenue enhancement program, we can look at specific cases so that we can help you know where to look on the claim and understand when something can be disallowed or denied, right? Because they have different, you have different recourses you can take if something's denied versus disallowed. So you can't really make a blanket statement, but in most cases, the answer would most likely be yes, you'd have to feed 42. But we can look at those specific cases and go over that with you if you have any questions.
So an SRP question, do all SRP require an FMX within 12 months for payment?
They will. If you're outside that 12-month time frame, you can try and submit it, but chances are, well, here's the thing, if there's bone loss on there and you haven't, it comes back to the treatment that is required. If you're within 12 months, you've got a greater chance of getting that claim denied, if approved. If you're on the verge of timing out, then they may ask for x-rays. So if you're even close, I would predetermine it just to make sure, because that'll help you understand what kind of treatment you need, what kind of treatment would be approved, but also what documentation you would need before treatment's rendered.
Okay, two more, actually one more just popped in, so there's two left. For patients
Okay.
who come into the office, the first time normal is a complete exam, a comp exam. If we see during the examination patient is an SRP, when would we need to use D0180?
Love it. Joseph, you're reading my mind here. Exactly right. This is a huge opportunity for dental offices. And understanding the difference between a 120, which means the patient's been seen before in your office, essentially, right? A 150, new patient. Now, the problem with the new patient is they could be a 150 or a 180. The problem with a 120 is they could be a 180 as well. So what I'm saying is, whether the patient's been seen in your practice before or not, and they present with signs and symptoms of periodontal disease and or smoking, diabetes, things like that, that's when you flip to a 180. Because with a 180, that means you're going to do a comprehensive periodontal analysis, which includes a 6-point comprehensive periodontal charting. Now, you could do that in a 150 or a 120, but the 180 fee should be higher than the 150 fee, which should be higher than the 120 fee, because you're actually doing more in the 180 fee. And there's an increased chance that the patient presents with signs or symptoms of periodontal disease. So once you see something that you might consider the patient to me may have periodontal disease, the first thing you need to do is rule that out or rule it in. So whether it's a patient that's been coming to you and you've been doing 120s for the last 3 years, but this time they come in and there's bleeding all over the place, bone loss that you notice on the bite when they hadn't seen before, or they're smoking, or there's signs or symptoms of periodontal disease or risk factors, then that's when you trigger the 180. Now, the challenge is the 180 is going to burn a frequency with the 120 or the 150, but that's not the concern. The concern is always doing the right treatment and coding for what you do. So whenever I see a patient that show signs or symptoms of periodontal disease, whether they're a new patient or an existing patient, I flip to the 180 and submit that 180 because it does two things. One, you've documented that that patient may have periodontal disease. Then you, at the end of that chart note, you decide, you write your diagnosis. Patient does or doesn't, and then you diagnose that patient. But if we don't flip to the 180 and we keep doing 120s, and they got periodontal disease or they've got gingivitis and we don't treat it, then we're actually not telling the patient that they are at risk. And that's when it could become problematic for them in the sense that they're not getting the care that they need and they're not accentuating their home care as they should to combat this disease. And then we're also not legally documenting that in our records. So Joseph, love that question. In summary, anytime you see signs or symptoms of periodontal disease or risk factors, that's when I would flip to the 180.
So the questions keep coming. How much time do we
Okay.
have, Dr. Jim?
I'm in it. This is what happens when you join CodeAdvisor. So just so you know, for 479 a year, I don't know anybody else is going to answer questions like this. And you get all that documentation at your fingertips. So highly recommend if you like what we're doing here, please consider we're going to send you an email with the code that you get the first month free. So at least sign up for that, see how you like it. But let's keep going on to these questions. What's the next one?
Okay. Can you see him? Do you want to read it?
I'm trying to think now. I see anonymous. What do you do if you have a patient with a history of scaling replaning and now insurance is denying claim of retreatment due to no bone loss? Well, it's interesting. These are what we're seeing with with Code Advisor and then our revenue enhancement is we all have the same questions, right? And the challenge is we feel like we're on our own and we're isolated. So, great question. I would go back to the facts, right? Let's look. Is there bone loss on the x-ray? If there is bone loss on the x-ray, the patient has, I mean, the definition of periodontal disease starts with bone loss. So if they're denying it, I actually, and I've done this with our eAssist clients. Um, Again, when you sign up for eAssist, you get all of us. And if you get a claim that doesn't get paid, we come in there and we help you with it. Let me go back as far as I can before I see it. I draw these lines out on the x-ray. Now, I will tell you, if you're going to draw lines, give them both. You have to give them the natural x-ray. And then if you want to document, and I wish I had these cleaner, but I would do this as well, but side by side. And then you submit and you say, there is existence of bone loss. This patient is, if it's new to your practice, you just got to figure out when the last time they had scaling or root planing. If they're new to your practice, they might not know. So that's where we can help you with revenue enhancement. We can talk to you about these opportunities and how you address that. And truthfully, in the coordination benefits training too, we get into that. But I've drawn this out for many patients and many eAssist clients. Now, let me show one other thing real quick. Let me go back. Dawned on me that we never really finished our questions here. So the reason I want to show you this is because of what you just asked. So one of the first things I did was I said, is there bone loss? An office submitted this claim multiple times saying there's bone loss. There's no bone loss, right? That's the challenge. So they kept appealing, right? So that was the first one. This is the second one. Again, no bone loss. I know it's shocking, but maybe now that when you look at it, you'll see it. Now, the question then becomes when you look at this one, there's definite bone loss, and you've got calculus. Again, calculus, as you can see here, is on the enamel. So it could be subgingival, but it's not on the cementum, which means an insurance company does not care about calculus. You can point out calculus all day long. It'll help you if there was no bone loss in calculus, potentially get a 4346 paid. So don't ignore it, but don't rely and say, oh, this patient has calculus, therefore they need X, because it could be either 4346 or scaling root planing or 4910, depending on the situation. So in summary, let me go back to your question. Make sure I get this right. Okay, so do you recommend submitting a pre-D? Oh, that's a different question. Um, okay. Did I answer that question, Jack? I'm trying to remember what the
Yeah,
rest of
you
it was.
yeah, you answered that question. I
Oh,
think
yeah, I
everything.
think in summary, if there's bone loss, you write it out and argue it. Like in this case, definite bone loss. So you write back saying patient presents with X amount of, 2, 4, 5, 6%, 10, 2 millimeters, for whatever you want to say, bone loss. Patient new to the practice, patient can't remember, whatever it is. If you know when this last scan and root planning was and it was more than 3 years ago, that's an absolute green light. So I hope I answered that question. And if I didn't, just I'm gonna we'll send you the code in the email. Just reply to the email and we'll follow up with any other questions you have. All
Okay.
right. Do you recommend? Go ahead.
Are you ready? Yeah, go ahead. Read that one. Do you
Yeah.
recommend?
Submitting a pre-D for all. The dentist before me submit. Oh, for everything. Oh. Okay, anonymous attendee. Boy, that's a painful question. That's a lot of work. Um, I don't because well, here's the thing. The first thing I would recommend you do, if you think about how much time that you spent predetermining or submitting predeterminations, I know it's painful, right? You think about all those waste hours and just following up, it's an absolute nightmare, a lot of work. So I'm hoping that what we shared with you today is going to give you some more insights on to know when you think it'd be close. Um, this. Again, this was 3 times they appealed this one, and God bless them, but they're never going to get that paid. So if I had this case, absolutely not predetermined. I'm going right ahead. As long if it's my patient and I know that they haven't had scaling root planing in their history, the only time they're really predetermined is if you don't know the history and you can't prove the history, then you might want to because it could get a little squirrely. But in this case, I would not submit this left one for scaling root planing. I would definitely submit this right one and not do a predetermination. So I would say try to avoid predeterminations if you can. I guess this is the way to say it. If you've got the proper documentation, which means previous scaling root planing, if any, x-rays that show bone loss like you have here, beautiful, no overlapping, no foreshortening or elongation, you're solid. If you don't have that, that's when I typically do a predetermination. I hope that helps. All
Okay,
right,
now
if a full mouth is needed, oh, sorry, go ahead.
go ahead. We're at Carla. Yep.
But a full mouth has been done 2 years ago. Love that. No, just take bite wings and submit it. Yep, love. Okay, so I guess I better read. Can you see the questions that are on my
Sure.
screen?
If an FMS is needed to justify an SRP, but an FMS has been done 2 years ago, for example, do we need to take a new FMS? Or if the insurance company pays only once in 60 months for an FMS and now they ask for one, can we send them the last FMS taken?
Great. Now, Jack, just so I know, I have the Q&A open. Is that something visible to everybody or,
It's open to it's probably visible to everybody. It's
oh,
under
can you,
open questions. Can you see it under open questions at the top?
so I'm displaying it now. Is it visible or are you just,
Uh-uh, I
oh,
can't see.
okay. All right. So that's helpful. I just want to make sure we all know. So, um, again, we only want to do treatment that is necessary. I would never irradiate a patient when they're not due just for insurance, right? Every dentist has to make that determination. In this case, 100% would submit the full mouth series, and I would wonder when they were due for bite wings next, because the only way to know that, so you say if a full mouth series, okay, but a full mouth has been done, so the way I read this is I'm thinking this patient comes in for a cleaning. They're only due for bite wings and maybe two PAs, right? So, and you take those bite wings and you see this patient on the right, 100% submit the bite wings and your most recent full mouth series. So you basically submit everything you have. If you took 4 bite wings and 2 PAs, submit that plus the most recent full mouth series, even if it's over a year old. And then that's a good time to do a predetermination because you do not want to have the patient be held, if the insurance, I want to know what the insurance is going to do before I treat that patient. So I would put that through as a predetermination and say, this is what I have. And they would probably look at it and say, go for it. And if they don't, that's when I would call and talk to the dental director. So I know I told you, I, I got a lot of calls from patients and from providers and that's when you request a peer-to-peer. Say, look, I understand your policy, but this is where I'm at. And what you described is exactly right. Patient's not due for a full mouth series for 3 years, it looks like, or 4 years, depending on how the 2 years ago. So 3 years, whatever it is. I submitted the bite wings. X bone loss is evident on the bite wings. If I need to, I draw it out, send it in again with the original alongside and say, can we resolve this? And most of the time, I would hope that they would, because, like we said, you're not going to bring the patient in to irradiate them unnecessarily. You've got the documentation that supports your position. All right, next one. Good question. Thanks, Carla. All right, if a patient is not yet ready to do a 4341 for whatever reason, how do we code? Oh, for the following cleaning visits if they choose to continue care? Boy, that's such a tough question. So we have to make this easy for ourselves. If a patient, and this gets into a whole nother aspect of treatment, and we would need to talk to you in a revenue enhancement about that one because there's certain things that you can and there's certain things you might want to consider saying and sometimes things you definitely don't want to say to a patient. But if you're diagnosing them and your treatment recommendation is X, regardless of whether it's scaling, root planing, endo, whatever it is, and they say, even if they say I don't want x-rays, then you don't have all the information, or potentially you're not providing the treatment that's necessary. And then that gets into a question of what are you legally obligated to do. So unfortunately, these are the questions we can't answer from a legal perspective, but we can discuss the workarounds in a consultation. So even if you didn't want to do the revenue enhancement, we can help you through a consultation and get those kind of questions answered for you. So let me just make sure I read this right. If the patient is not ready for whatever reason, how do we code the following cleaning visits if they choose to continue care? Yeah, I've had this happen several times, and we've had this in revenue enhancements as well. And I do remember having had to, I think we had to get a legal document, but um, so yeah, if you want to dig it a little deeper into that one, we can. Unfortunately, that's outside the scope of what we can offer here at this because it does include legal. So sorry, anonymous attendee, but I appreciate the question. All right, Kim, how often can you claim 180 or 4346? Well, let's look. All right. Now I'm going to teach you how to use your new code advisor that you're going to get. So I'm coming in here. I'm going to click on code advisor. So I go to dentalcoding.com. I click on code advisor. I type in 0180. Then I come over here and I hit search, or I can hit enter. Let's go back to your question. Make sure I get this right. All right, search. How often can you claim a 180? So we come down here and we look at limitations, and then we say, read through it. Some payers reimburse every 12 to 24 months. See how easy that was? Kim, are you excited as I am? I mean, that's pretty cool. So right away, every 12 to 24 months, right? So now let's go over to a 4346. Actually, Jacqueline, is this too small? Should I make this bigger?
Yeah, I can't see it, but then my screen's really small right now. Let me
All
see.
right, so there it is, every 12 to 24 months,
Yeah, that's better.
others every 3 to 5 years, and some once in a lifetime. Now, this document, everything you see here is everything that's in our code. Oh, it's right here, our Coding with Confidence book. So this big book is great. I love having the paper, but everything that's in here is also in the Code Advisor. And in fact, sometimes we can do more on Code Advisor because we can hyperlink and update it in real time. So if we go to 4346, and let me just see, sometimes there might be a 4346 here we can click on, but if not, we'll click search. All right. And let's go down to frequency limitation. So it's a fairly recent code. It's actually been out for a couple of years now. And it falls under the frequency limitations associated with the prophy, but not always. So this is what I was saying on the 4346, and why this chart and this graph is so important, that ideally a 4346, if warranted, would be, okay, this is what I tell my patients. All right. And it was great during COVID because most of them had missed their 6 month appointment. I would tell them, look, we're seeing signs and symptoms of gingivitis. The good news is gingivitis most often is highly treatable. And what we need to do is really just do a cleaning now, and then have you come back in 4 to 6 weeks and then do another cleaning. But I'm going to need you to make sure that you match our efforts during your home care, right? So and then what I tell them is, now what's going to happen is in 6 months, your insurance may not pay for that cleaning, but we have to do this in order to get you caught up. If we don't do this and we leave the gingivitis untreated, then it could, progress and become more problematic. And you always want to be truthful and say it with your own words and how you'd like to say it, but typically it shares a frequency. So if it's 1 per 6 or 2 per 12, then that's where you might run into the third one getting denied. So, but I wouldn't shy away from that. I would say that and have the patient own this. And truthfully, most of the time when I tell patients that, they're excited that we're taking care of it. And I go into the analogy of a splinter in your finger, and I said the longer you leave it in there, it gets red and gets hot. And if we don't take it out and let your body have time to heal, then it's going to progress and become more of a problem. Then they say, "Oh, I love that idea. Great, let's get this taken care of." So, hope that answered your question. If we are eAssist clients, do we have to do this, or eAssist have to appeal with the x-rays and drawings? So, Marianne, I forgot to mention, if you're an eAssist client, you already get Code Advisor. It's kind of like Oprah. You get code advisor. You get code advisor. You get code advisor. So talk to your SC and say, hey, how do I log into code advisor? Because I get that for free. You do. Now, your question is, um, how do we have to do this or eAssist have to appeal with the x-rays and the drawings? Yes, the eAssist team will appeal, but what we need to do is make sure that your team captures the information and documentation on the data service. And then if you ever have a problem, you tell them to call Dr. Jim and I will get on it and personally take care of it. And I've drawn these out for many clients. I've taught SCs. Our success consultants are the ones that are. So essentially, for those who don't know, eAssist hires the best. I mean, just to give you an idea, I struggled to pass the test to become an SC. In fact, I failed it because I don't ever do dental billing on that side, right? These are super smart dental professionals who understand the dental billing. And usually you have a team of at least two or more on your office, and they're doing this behind the scenes for you. But they can only process what you give them. It's no different than me as a dentist not capturing the x-ray or not saying, hey, we need to do a 180 because I'm seeing signs and symptoms. I've got to do that on the data service because as far as I know, none of us can take a pre-op x-ray of a tooth after the crown's cemented, right? And insurance doesn't care after the stuff's done, they want it before. So it's imperative that there's teamwork. But Marianne, if you have any questions, make sure you tell your team. I was on a call with Dr. Jim. I want to make sure this is being done. Please reach out to Dr. Jim. They'll send me a message and we'll jump on it and make sure it's being done for you. So Marianne, great question. All right, love these questions. Okay. If a patient doesn't have more than 2 millimeters of bone loss, but they do have pocket depths more than 4, doesn't that mean that they have detachment and the doctor can still 100%? That's a 43, 42. Nailed it. 100% right. Yep. That's the difference, right? So that's not a 43, 41. That would be localized and a 43, 42. So Kendra, love it. Spot on. You're the type of people that eAssist hires because you guys get it. And love the fact that you're doing this for your office. And hopefully, that you can continue to do that for them. But if you have any questions, let me know. You're 1,000% correct. Support you there. If you have any questions, let me know. How to handle an SRP pre-auth is denied. I only laugh because it happens all the time. And I laugh to cope, just so we all know. Is not eligible due to age, but the age is 40. But patients do have history of scaling or replanning, have been on perio maintenance for, oh, that's awful. Oh, I want to get in on that one. All right, anonymous attendee. Yes, we would appeal that, and we'd appeal that, and I would use my dental director language to try and get that paid for you because nothing burns me more than that. Like it seems to me, and I can look at the X-rays and tell you right away if AI is going to approve it, or again, not all payers have AI, but that's one that we would really look at because to me, what you're saying, they've had a history, they've been on perio maintenance, and they're not eligible due to age. No, I can't add that up in my head. So I would definitely appeal. If you need any help or questions, let me know. Here's what's great about CodeAdvisor. $479 for the year. You get to send that to us. We get to tell you, we get to look at it, review it, and tell you and give you some guidance on what to say back to the insurance company. If you get one claim paid, you paid for the whole thing. And truthfully, if you look something up and I'm going to do it for you. I'm going to type Maryland in here just because it's fun. Oops, I got to type it. But this is what I'm saying. To me, I don't know how anybody can practice without CodeAdvisor because it's just so handy and you get to ask us questions. So if I typed in Maryland only because it's fun, these are all the codes for Maryland Bridge. Just want to throw that out there. Not that we're doing that much anymore. Curodont is the one that we get a lot of questions about. What's this Curodont product? Hit search. All right, can you bill 180 with a 4910? Yes. Now here's the question. So there's the codes that come up. Just things like that. I just want to show you that you don't have to know the code. You can know the condition and type it in. And oh, I forgot to do this one for you. Boy, I'm leaving the best parts out. I'm so glad you guys are staying on. You're getting an extra. So if you type in eval, let's say, and you get, oh, like, wow, that's a lot. Well, I only want the evals for perio. So you can go to the category. You can't do this in the book, but you can do it here. Oh, there's the evals. So if I do this one, I go to 4910 and I look in here and I'm like, ongoing periodontal maintenance does not include the periodontal oral evaluation or comprehensive periodontal evaluation. So there's your whole section to answer your question. And you can do that without calling the insurance company. Love that. Right at your fingertips. So you can even search and say, well, is there a 180 in here? Oh, there's a lot of 180s. All right, now I got to look at these and see where this comes into play, right? So these are the questions that you would have at your fingertips answered, and you look like an absolute rock star. Plus, if you're in an office situation, you can have this open on, I think it's 3 computers in your office. So 3 of you get to use it for the same price of $479. Boy, I'm not a salesperson. I like to educate, but I'm convincing myself that we've got something here, and I hope that it's helpful to you. So, Marcus, please take a look at this. Please get your free month and try it. But yeah, I hope I answered your question there. What is the time frame you should bring a patient back after 43, 46? Great question. I don't know if we have that in here. Let me check. Um, the time frame is the discretion of the dental professional. Now, sometime it's really key that the patient owns the home care portion. I don't know time or effort. I would just, that's actually a good question. I'm gonna make sure we add that. Yeah, oh, here it is. All right, so 43 foot is provided to remove all deposits and allows the tissue time to heal following the diagnosis of generalized. Typically, a prophylaxis would follow. There we go. Well, I always say 4 to 6 weeks. It's really up to you as the provider. If you look at a patient and it's really a difficult situation, you're like, wow, I need to make sure you use your flosser. I'm going to tell you, do over home care, proper oral hygiene instructions. They need to do what they're going to do at home because no matter how many times you bring them back to do a 43, 46, or a 110 in the office, if they don't match that effort at home for home care and they're compliant, it makes sense that the healing is going to be insufficient or delayed. So it's up to you as the provider. It could be 2 weeks, 4 weeks. I typically do 4 to 6 weeks. And then when they come back, number one, it's not as painful. So if they do have any subgingival calculus that's without bone loss, you can get to it without there being this eruption of bleeding. And ask your hygienist. I remember saying that we're going to go and pull the 180s to 43, 46s, but ask your hygienist. How do you handle bloody prophies or dirty prophies? That's the terminology. You guys might use a different one, but those are the things. Ask them because that's typically, if 43, 46 is low, that's probably where the 43, 46s are, and you're treating it as a 110. The problem with treating a gingivitis patient as a 110 is you're telling the patient they don't have gingivitis by submitting or documenting a procedure completion of a 110. You're basically telling them it says prophylaxis, that everything's fine. So a patient who continues to get a 110 and a 1110, right? And then all of a sudden they're like, you say, oh, you got periodontals. He's like, well, how did that happen? I've been coming every 6 months and you telling me that my teeth are fine and you're just cleaning them. Now I've got bone loss. Isn't there anything in between? Well, you've had gingivitis this whole time, but we didn't want to charge you. Or you have to code for what you're doing and you have to code the proper diagnosis because codes aren't just for, billing. They're also for proper documentation and a part of your legal record. So great question. It's up to the provider of care. And typically you don't want to do the next day. You've got to have healing time. I'm glad we had that in there. So at least 2 weeks, could be 4, 6 or more, depending on what you think they need to get their home care in order. All right, I think this could be our last one. Do you ever advise referring patients to see a periodontist if their deep cleanings are denied? If their deep cleanings are denied. So I'm thinking scaling root planing are denied. Yeah, yep, 100%. And that goes back to that legal side of things because, oh, you're saying if they're denied. Oh, sorry. I thought maybe if they deny treatment. But either way, yeah, you can. The problem that we have as professionals is, again, we've got to diagnose correctly and we've got to treat accordingly. And if the patient gets in the way of what we believe is proper treatment, then that brings up the legal question of what can I do? And what risk am I assuming by not treating the way I professionally believe I need to treat? And that's questions for you and a lawyer, but we can kind of give you some guidelines of what this looks like. So there's never a harm in referring to a periodontist, other than potentially losing. If it's what's best for the patient, there's no harm in referring to a periodontist, and that's a good option if the treatment isn't being. I just kind of leave it at that. So, answer your question. I would probably do consider referring to a periodontist if that's in fact what the patient needs, and we're not getting the support that we need to complete the treatment that needs to be rendered. All right, Jacqueline, I think we did it.
I think that's it. Good job, Dr. Jim. That was a lot of questions, and I really appreciate you just taking the time to stay on. We still have a truckload of people with us, so let's wrap this up. At eAssist, we're grateful. Congratulations. The Kahoot game was so fun. Congrats to Eric.
Uh,
That
that
was
was,
so.
yep, sorry. Go ahead.
You're good. Thank you, Dr. Jim. That was really, really fun. I appreciate you doing that. Today's session is a perfect example of how eAssist Dental Solutions and Practice Booster work hand in hand to really empower dental teams. At eAssist, our mission is to help practices collect 100% of what they're rightfully owed through clean claims and timely follow-up and expert support. But then Practice Booster complements everything eAssist does by providing the industry's most accurate and up-to-date coding, documentation, and compliance resources. And together, we aim to give you not just the tools to fight claim denials, but also the confidence to prevent them altogether. So, one last thing before we go, I want you to just know that we'll probably send out a little survey with just 2 questions. We'd love your feedback. Your feedback helps us know what kind of things you're looking for in the future and how our webinar was today. So thank you. Thank you again, Dr. Jim. I appreciate your time.
Thank you all so much. Make sure you've got your coding assets up to date. If we can help you with a fee analysis, which is $7.99, or a revenue enhancement for $24.99, be happy to do that. We've got the 2026 books we're working on right now. Those 60 changes. It's a lot, so we're stuffing all that great information in there for you. But Code Advisor is something you can access now right away. And I forgot to show you one of the nice things about Code Advisor is you can scrape off some of the documentation and drop it right in your claim form, which is really helpful. Or, if you're trying to communicate back with your provider, sorry, your payer, you could say, well, the ADA says this. I hit copy, paste it right in the claim form. It's a great way to help enhance communication. So I just wanted to let you know that that's still out there, and really appreciate your time today. Great questions. We're here to help you. Go to dentalcoding.com or dentalbilling.com for eAssist, and we're so grateful for your time. Wish you all the best.
Thanks, everybody.